Welcome to Oncology Radio. We are bringing you the latest information in the arena of oncology. Every episode brings you a new Maryland Oncology Hematology physician host, along with special guests in cancer research, new trials, cancer treatment, nonprofits, and cancer care. Maryland Oncology Hematology is broadcasting Oncology Radio from one of our 14 locations throughout Maryland. You can find Oncology Radio on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. So stay tuned and welcome to Oncology Radio.
Welcome to another podcast of Oncology Radio. I'm Dr. Andrew Maynor. I'm a medical oncologist at Maryland Oncology Hematology, and I will be your host today. I'm joined by a very special guest, Dr. Rachel Brem. Dr. Brem is a professor of radiology and the vice chair of radiology at the George Washington University School of Medicine and Health Sciences, as well as the director of breast imaging and intervention. She's the chief medical advisor and founder of the Brem Foundation, as well as a well-respected advocate for women's health. Thank you, Dr. Brem, for joining us today.
It is my pleasure. I'm delighted to be here today.
I'm hoping that we can discuss some of the controversies and some of the innovations in breast imaging in 2020. But first, I wanted to give you a chance to share your story about how you became interested in breast imaging and became such an important advocate for women's health.
Sure, I'd love to do that. So every woman in the United States is impacted by breast cancer. As we all know, 1 in 8 women will develop breast cancer. For me, when I was 12 years old, my mother developed breast cancer, and it was in the 70s. So it was not as discussed or openly known at that point. So my mother disappeared for about 3 weeks, never to return, the red-haired, vivacious person that she was. But she was told that she would have 6 months to live, and she died many years later at the age of 77, cancer-free. So as a young child, I vowed that I would do everything I could to make other 12-year-old girls not be in the shoes that I was, and to do everything I could. So I followed that passion through medical school. I was a medical student at a very exciting time in terms of breast cancer screening. I was a medical student in New York at Columbia at a time when the Health Insurance Plan of New York was doing the seminal trial showing that screening mammography is in fact absolutely life-saving. So I decided to get on that bandwagon, became a radiologist, and then have devoted my life to breast cancer. But as life would have it, twists and turns happen. So when I was 37 years old, the director of breast imaging at Johns Hopkins at that time, I was trying out some ultrasound equipment and found my own breast cancer. So here I am with a 12-year-old, sort of seeing history repeat itself, but with much more information and in a way sort of prophetic, because I was using ultrasound as a screening tool, which was not used in those days, but is widely used and incredibly effective at finding breast cancer in women who have dense breast tissue, which I did. So it was a very personal journey, which I feel the most fortunate to have started and to continue on, in that I can both share what other women are feeling and going through, as well as can bring to that the information and the incredibly impactful impact or result of screening for breast cancer.
Wow, that is an amazing story. I mean, that really explains how you've dedicated your life and your heart and soul to this issue.
Yes, very, very lucky to have passion. And, it's the silver lining to the gray cloud where there are negative impacts, but they're incredibly positive impacts. And I feel very fortunate that I can share my experience and have a better understanding of what my patients are going through. Of course, everybody's journey is different. Everybody's response is different, but it is definitely an insight that I have to say I was fortunate to have, that I could bring with me to the women that I care for.
what I'm hoping to do today is try and sort of ask you to help us help our patients understand some of the controversies around mammography so that we can make sure that people take advantage of all the screening modalities available so that they can find their cancer as early as possible. I know one of the things that I've been answering questions on every day in our office lately is on how often people should get mammograms, particularly during COVID-19. People are scared, particularly our older patients, to venture out to the radiology office. And I was hoping you might share some insights in that.
Yeah, so those are two very important issues. One is when to screen for breast cancer, and the other is how to screen for breast cancer during the time of COVID. So let me start with the latter, if I may. So there was a time where largely across the United States, we were not screening for breast cancer. In fact, we were not treating some breast cancers with the typical way that we treated it before COVID, because we were under severe pressure to save resources that were needed for this increasing population of COVID patients. However, that is past, and we have learned a great deal. We have learned how to protect ourselves and our patients. We have learned the importance of what you've heard about, of deep cleaning, of hand washing, and of course of masks. And what we've learned recently is that, double masking, if I'm wearing a mask and you're wearing a mask, it's a very safe situation. So although we did not do breast cancer screening for months, with the real fear that we would be finding later larger breast cancers, most breast programs, most breast centers, most mammography centers, and breast imaging centers are back up and running. And what I have to tell whoever is listening, women that are listening, is that we take great care with a lot of knowledge as to how to protect you. And everything is a risk benefit, but the benefit of finding an early curable breast cancer far outweighs the risk of getting COVID. You are safe when you come to our facility, when you come to other medical facilities. You will be asked about symptoms. Everybody is asked about symptoms. Temperatures are taken. Information is gathered to be assured that a person is not currently ill with COVID. And then, of course, masking is a requirement. We deep clean in between every patient. We have more than 6 feet between patients. In our practice, we don't put 2 patients in the same room at the same time. So we are taking great care to assure that women are safe when they come for their life-saving mammograms. And so the message is that every facility is taking different precautions, but we are all taking precautions, and we are unaware of any patient, not at our practice, but others as well, who did become ill with COVID as a result of coming for a mammogram. So the bottom line is, yes, we stopped for a while, but no, you should not delay your mammogram any further, because we are beginning to see some larger later breast cancers that, had they been found earlier, might have had a different outcome. And with that, I think that's a really good segue to ask, what has happened to breast cancer, to survival for breast cancer over the past few decades? And the answer is that there's been a 40% reduction in the death rate from breast cancer over the past 2 decades. And that is thought to be half due to the extraordinary improved therapies for breast cancer, as well as to as a result of breast cancer screening. And breast cancer screening is a critical part of that profound decrease in breast cancer mortality that we've seen. But so when should you start getting a mammogram? And that is a very controversial question. If we had this discussion some time ago, the answer would have been much simpler. But there are many different recommendations. The USPSTF recommends starting at 50 and getting a mammogram every other year. There are some organizations that recommend starting at 50, getting a mammogram every year. And then there are others like the American Cancer Society and the American College of Radiology that, not the American College of Radiology and the American College of Surgeons that recommend getting a mammogram every year starting at the age of 40. So why all this controversy? One thing that everybody agrees with, and this is critical, so please hear this, is that if you get a mammogram starting at the age of 40 every year, you have the best chance of finding an early curable breast cancer and will most significantly impact their mortality rate from breast cancer. When the USPSTF came out, the United States Preventive Services Task Force came out and recommended getting a mammogram at the age of 50 every other year. They said that if you do that, you will maintain 88% of the decrease in the mortality from breast cancer, which means 12% of women whose lives could have been saved will not be saved. And even the American Cancer Society, any organization that recommends less frequent mammograms than annual mammography, or starting at an age older than 40, the data supports unequivocally a higher death rate from breast cancer.
That's a
so
pretty
the question
remarkable.
Is why?
That's a pretty remarkable set of data, and really, I think, creates an enormous amount of confusion, I know, amongst my patients and some of our referring physicians.
Yep, absolutely. So, I guess the question is, and the question I frequently get asked is, why? If we can save lives, why don't we? So the answer is that there are what is termed harms associated with mammography. The number one harm that was cited by the United States Preventive Services Task Force was emotional distress and stress. So there are a number of things that I'd like to address with that. Firstly, there have been studies that have shown that if you do have a higher stress rate from getting a mammogram, it's transient and it doesn't stay forever. The second is, I find it that in the year 2020, women are educated, empowered, and shouldn't they have the opportunity to decide if they want to go for their mammogram or not? Sometimes I feel like I'm living in the Middle Ages when people say, oh, you poor little women, you shouldn't be stressed about mammography. But what I can assure you is that if for all of us who have the privilege of taking care of women with breast cancer, if you tell someone that she has a mammogram, which is a false positive, meaning that there is something on the mammogram that has to be worked up, that might even require a biopsy, which is akin to going to the dentist, that it would cause some stress, but it is much less stress than telling a woman that she has metastatic disease and has an incurable breast cancer. So it is really critical for everyone listening to understand that women should go for a mammogram every year starting at the age of 40. And the other risks of mammography are radiation. But you get more radiation flying to California 4 times, although very few of us are flying to California these days. But it really is minuscule, and there has never been a reported case of breast cancer as a result of the radiation from mammography. And finally, there's something called false positives or overdiagnosis. And that means that we will find a breast cancer that if you would have left it alone would not have killed that person. Predominantly low-grade ductal carcinoma in situ. But the problem is we don't know which ones will become killer cancers and which ones won't. So there's 2 ways of looking at it. One is that we give each woman the opportunity to have early curable breast cancer. And some women will get treated who, if you had left their cancer alone, would not have succumbed to their disease. The other way, but some will. The other is we'll treat everybody and we'll give everybody the opportunity for a cure. So those are the reasons that some organizations and associations do not recommend screening mammography every year. And of course, the elephant in the room is the cost of mammography, that there is a substantial cost. But as I often say when I speak to women in a room, raise your hand if you're not worth a mammogram. That could be life-saving. So that's how I view screening mammography.
I think one of the controversies regarding starting mammography earlier is the increased breast density in younger women that makes it more challenging to interpret a mammogram. Is that correct?
Absolutely.
So I know that you've done a lot of research and advocacy work surrounding breast density. Can you explain a little bit what it means to have dense breasts?
Absolutely. So when you look at a mammogram, breast tissue is white and breast cancer is white. And if you have dense breast tissue, you have more background white. It's kind of like trying to find a cloud in a cloud-filled sky. You lose that contrast of the non-dense tissue, which is dark, with the breast cancer. So having dense breast tissue is kind of the perfect storm, because not only does it make it more difficult to interpret mammography, but women who have dense breast tissue have a substantial increased risk of developing breast cancer, up to 4 times the risk of a normal woman, if you look at women with extremely dense breast tissue. And the other thing that's really important to know is that 40% of American women have dense breast tissue. So it's not a small number. The only way you can tell if you have dense breast tissue is from your mammogram. So again, it's kind of the perfect storm. Mammography is less effective and your risk is higher. But we now have what's called risk-based screening, which means that women who have dense breast tissue have the opportunity and should be offered additional screening with ultrasound or MRI. Both of these technologies can find these mammographically hidden breast cancers. And the other thing that's really important is that these mammographically hidden breast cancers that we find with additional ultrasound or MRI are really important because they're small, invasive, predominantly node-negative breast cancers, exactly those breast cancers that we need to find in order to save lives. So what should women do? Well, there is 38 states and the District of Columbia have laws that require women to be told whether they have breast cancer. Whether they have dense breast tissue. Maryland, Virginia, and as I said, DC is among them. DC is unique, joined by 7 other places in the country where insurance is required to cover these additional screenings. And we know that we can find 25% more cancers if we do screening ultrasound in women with dense breast tissue. So if you're told that you have dense breast tissue, you should advocate for yourself, as we talk about incessantly at the Brem Foundation. Every woman is her own best advocate. Every woman knows herself the best. If you go for a mammogram and you're told that you have dense breast tissue, you should insist on additional screening with ultrasound so that you can do everything you can to optimize the chance of finding early curable breast cancer.
You mentioned both ultrasound and MRI as potential enhanced imaging options for women with dense breasts. Can you explain a little bit when an MRI might be appropriate and when an ultrasound might be appropriate?
Yep, and I'd be happy to. So ultrasound is the same kind of technology that we use to look at babies in utero, prenatal ultrasound. It doesn't use any radiation. It doesn't require any injection. It doesn't hurt. There is some compression, and there are now newer technologies like automated breast ultrasound, and another one that I have the privilege of working on called ultrasound tomography, which can be much more comfortable, much less compression, and find these important additional cancers. So you can do ultrasound with handheld ultrasound. You can do ultrasound as we have in our practice with automated whole breast ultrasound. And we are looking at this emerging, very exciting technology called ultrasound tomography that can not only give us information about ultrasound, but about more information about a woman's breast density as well as her risk of breast cancer. And we find about 25% more cancers. MRI, or magnetic resonance imaging, is a different technology. It actually uses magnetic fields which change the property of the tissue that allows us to see differences in tissue and find breast cancer. We actually find more cancers with MRI than we do with ultrasound, but it requires an injection of a compound called gadolinium. So one, it requires an injection. Two is it's a fairly long study. And there are some concerns about gadolinium. We have recently learned that gadolinium can accumulate in parts of the brain. We don't think that it does anything nefarious, but we don't know. And so we have to be judicial in its use. And also MRI is just not that widely available. It's fairly expensive. But the decision, most screening of women with dense breasts who don't have any other clinical findings. So when we talk about screening, we're talking about women who have no signs or symptoms of breast cancers, no lumps, no dimpling, no new onset nipple discharge, no new lesions on their breasts, nothing. And if they do have a normal mammogram, a normal physical examination, and they have dense breast tissue, predominantly the next step is ultrasound screening, either automated whole breast ultrasound as we have here at GW, or a handheld ultrasound that some practices do. But automated whole breast ultrasound is more uniform and better tolerated, less painful by patients.
It's very interesting because I do get a lot of questions in my office regarding breast density because women see it on their mammogram reports now. And a lot of times the report comes without that extra bit of insight in terms of what you can do as a next step. Do you know if there's any work being done to try and provide that education both to referring physicians, but also to the patients themselves?
So every state has a different law. There is now a federal bill that has passed, the wording was written by the FDA, that all women in the United States will be told what their breast density is. Some states have additional information that says additional screening, such as ultrasound or MRI, can find these cancers that are hidden in women with dense breasts. We have that in DC. In Maryland, that's not the case. But I think there is increasing education both to referring physicians as well as to patients to advise them that having dense breast tissue is really important, both important in terms of finding cancers on a mammogram as well as the need for additional screening to optimize the opportunity to find early breast cancer. And we didn't really discuss it, but the reason we need to find early breast cancer is because not only is the outcome better, but the treatment to get to that outcome is less severe with earlier breast cancer. So it's much more cost effective. So for every reason, it really behooves us to try to find early breast cancer.
We've been finding, I know in our office anecdotally, that we've been seeing more advanced breast cancers because women didn't have the opportunity to get mammograms for several months earlier this year. So we really are, I know, trying to educate all of our patients to get back into the breast imaging centers.
Yeah. I think, this is a good opportunity to also talk about risk-based screening. So if you have no signs or symptoms of breast cancer and you go for your screening mammogram, that isn't the end of the road. Because as we just discussed, if you do have dense breast tissue, you should also get screening breast ultrasound. And there are some women who are at higher risk than that. Women who have a gene mutation, such as the BRCA1 or 2 gene, or women who have many family members, first-degree relatives, or multiple second-degree relatives with breast cancer, or other clinical situations which put you at significantly increased risk of breast cancer. So the American Cancer Society and the American College of Radiology recommends that women who have a 20% or greater lifetime risk of developing breast cancer get screening MRI every year. And we talked about that gadolinium, but the risk benefit is far in favor of having a screening MRI if you are at this significantly increased risk so that we can find these early curable breast cancers.
Every year, we meet many, many patients that have a new breast cancer, and in taking their family history, we uncover these long, complicated family histories of cancer. And it really does open the door to how many of these cancers could be caught earlier or even prevented had people been pointed in the right direction earlier in life. So hopefully over time, we will all get better at making those referrals and meeting those patients earlier. I know one of the other areas of some controversy in breast screening and catching breast cancer as early as possible is the role of breast self-exams and clinical exams. Can you speak a little bit to where some of the evidence is in that area?
Sure. So with regard to breast self-exams, there have been a number of studies that have shown that it doesn't make a difference. But I can tell you that not a week goes by that I don't see women who, in being vigilant, found their own breast cancer, that it undoubtedly would have been found later and larger and perhaps at a stage that would make it less favorable for treatment. So there's no harm. It doesn't cost anything. We have wonderful technologies to evaluate something that a woman might find. And I really want to reiterate again, the Brem Foundation is dedicated to optimizing every woman's chance of finding an early curable breast cancer. And we talk often about breast density, about risk-based screening, but we talk about physical examination. And that is because nobody knows a woman as well as she knows herself. If you are you should be doing breast self-examination. You should do it perhaps the same day of the month, the first day of every month, the last day of every month, the date of your birthday, whatever it is that you choose, and do breast examination, because if there's a change, you'll know it. So often women say, I don't know what I feel like. If you do self-breast examination every month and something changes, you will know it. So I would strongly encourage doing breast self-examination, because there's no downside and there is a potential upside.
I appreciate that insight. This is an area, I think, where there's a lot of controversy across all cancer types, where there's somewhat of a discrepancy between what the data show and what our experience is, because we all have had patients that come in having found their own cancers. Everything that you've shared with us is so incredibly convincing regarding the role of mammography and other enhanced imaging techniques. But nonetheless, in the media, we often hear about some of the controversies regarding screening. In 2015, the Washington Post ran an article titled "Stop Routine Breast Cancer Screenings. Science has shown they don't save lives." The debate around mammography is more about politics than science. Can you give us some insight into why articles like this seem to pop up from time to time?
It is one of the most perplexing things. I think it is a platform and a stage for someone's 15 seconds of fame. But the data is absolutely clear. The death rate from breast cancer has gone down by 40%. One of the greatest improvements in survival of almost any cancer. There are others that have done that well or better, but that, you think about 250,000 women in the United States every year who get breast cancer. The impact of screening mammography and targeted therapy together are really the reason that we have this 40% reduction. There is something else that everybody needs to understand, and that is something called intensity of treatment or intensity of care. When you look at the epidemiology of a woman who has an earlier stage breast cancer and someone who has a later stage breast cancer diagnosed, if they're both treated and they both survive, that's considered equal. But as we all know, and as you know better than anyone, the journey that the women have to go through for an early stage breast cancer as compared to a late stage breast cancer is not the same. The treatment, surgery, chemotherapy, length of care, consequences of care are very, very different for an early stage and a late stage breast cancer. And, as as a shout out to the medical oncologists and to the incredibly, effective targeted therapies that we now have, women with later stage breast cancer can survive and do survive, but it is not equal. The journey of the therapy of an early stage breast cancer and a late stage breast cancer is markedly different, even if the epidemiologists consider it the same at the end. It's not. So if you're armed with the fact that there's been a 40% reduction in the death rate from breast cancer, and that even if two women, one with an early stage and one with a later stage breast cancer, survive, but the journey that woman has to go through, these two women are very different, those are compelling reasons that an early breast cancer must be detected for both optimal care and optimal survival.
I think that really sort of emphasizes for everybody the need to continue mammography and do it in a way that's appropriate for each patient. One of the other questions that I frequently get from patients and from other physicians is when the appropriate time is to stop getting mammograms. At what age is it appropriate to have your last mammogram?
That's a great question. And over the years, people have done this study. They've said, maybe the breast cancers, there's some feeling that perhaps breast cancers in older women are more indolent, they're slower growing. So they've looked at women with older women with breast cancer who are not treated as aggressively. And guess what happens? They die of breast cancer. The thought was, well, if you don't treat them as aggressively, they'll die of something else. But that's not what happens. It turns out that if you don't treat elderly women or older women for their breast cancer, they will die of their breast cancer at much higher rates. So the recommendation is, as long as you have a life expectancy of 5 years or more, you should get your screening mammogram. Of course, if someone has end-stage disease and they are not going to be living 5 years, then that's not necessary. But if there's a 5-year survival expectation, then women, regardless of their age, should get their screening mammogram. And we know many, people who are in their senior years and of more advanced age that have wonderful, productive, fulfilling lives. So that is the recommendation: 5-year survival or more, get your screening mammogram.
And that 5-year number is not based on an average life expectancy for the population. It's based on an individual patient's other illnesses. Is that correct?
That's absolutely right. And it's important, again, let me refer back to the United States Preventive Services Task Force. They said they recommend screening mammograms in women 50 to 70. Why do they stop at 70? Well, the answer is because no one did the studies that they refer to. Not doing the study doesn't mean that it doesn't work. Those studies that were done have shown that screening mammography is very important in elderly or women over the age of 70 because it does save lives in that population as well.
I know a lot of the work that the Brem Foundation has done and that you've been a part of has surrounded increasing access to mammograms. Thankfully, we live in a part of the country where there are very skilled imaging centers really all over the place. But even today, not everybody has the access that we would like them to have. Can you speak a little bit to the work that you've done on that issue and where we can still make some improvement?
Yeah, absolutely. So the Brem, as I mentioned, the Brem Foundation is dedicated to 3 things. One is to women education, or people to education across all socioeconomic levels, because from the most underserved to the most privileged, there are lapses of information about breast cancer. The second is we do physician education, so hopefully there will be other podcasts like these. And the third is access. And so most women can access screening mammography. But what we have found and what we've recently done is that women may not be able to get to their free screening mammograms. And so we have developed the first partnership with a rideshare, with Lyft, that will take women at no cost to the women for their free mammograms, so they can avail themselves of this very important service. And in addition, the Brem Foundation supports a biopsy. So it turns out that there's quite a number of places that offer free mammography. And once you have a diagnosis of breast cancer, we can always find a program to help a woman get her care. But there was a lapse in the middle, and so the Brem Foundation supports the biopsies and additional studies that are necessary to diagnose breast cancer in women regardless of their socioeconomic level. So the Wheels for Women program, the partnership with Lyft, has been wildly successful. We're incredibly proud of it. And the Brem Foundation has also developed many educational resources. We had an Empower Hour with 3 extremely important educational programs this summer that featured Carly Fiorina, Jean Case, and Valerie Jarrett talking about different aspects of breast cancer in a conversation. You can find those at bremfoundation.org. You can find our award-winning video about risk-based screening and the importance of screening on the website at bremfoundation.org. I would encourage you to see the video. I think it's really fantastic, and it shares very important facts like that the number 1 risk factor for developing breast cancer is being a woman, and 3/4 of women who have breast cancer have no family history. So no one is immune from breast cancer. No one is protected from breast cancer. I can't tell you how many women who come to see me say, how can I get breast cancer? How is it that I have breast cancer? I go to the gym every day. I'm vegan. I have no one in my family. We can't prevent breast cancer. We're working on it, but we can't prevent breast cancer. And until we do, we really have to do everything we can to find early curable breast cancer. And that means know your risk factors, get risk-based screening, and advocate for yourself, because no one knows you as well as you do.
Thank you very much. As we prepare to wrap up, I wanted to spend just a few minutes talking about some of the stresses surrounding a breast cancer diagnosis, which you've alluded to a few times throughout our conversation. By the time a patient reaches the medical oncologist's office, they've often already obtained a diagnosis, or at least know that they have a significant problem. But we're often not the first stop. Often the first stop is either a gynecologist's office or the radiology office. I'm hoping that you can give us some idea of what that road is from an initial abnormality found on imaging to eventually getting situated with treating physicians.
By law, every woman who has a screening mammogram must get her results in language that she can understand within 30 days of the mammogram. And it's important to realize that if you get such a letter that says, please come back for additional imaging, it does not mean that you have breast cancer. Most of the time it requires some workup, either a mammogram, an ultrasound, some additional imaging, and most women leave with the knowledge that they don't have breast cancer. If a biopsy is recommended, then biopsies should be done minimally invasively, much like going to the dentist. You don't get put to sleep. It's done in the radiologist or another physician's office. We use local anesthesia, and there's no stitches. Many people come to us during their lunch and go right back to work after their breast biopsy. And it's important to know that less than 20% of women who do have a breast biopsy actually have breast cancer. So, in order to find the smallest cancers, we have to sample a lot of different findings on imaging, and that's how we can find the earliest breast cancers. So if you come in for a screening, you come in during COVID, you should have assurances that breast centers are taking the necessary precautions. You come in, most often screening mammograms are not read at the time that you're there. If you do need to come back, don't fret. Most often it's really nothing. And if you do need a biopsy, even then the vast majority are not breast cancer. And if you do have breast cancer, then we live in a very fortunate time where the result of the incredible therapies we have, the opportunities to find early breast cancer, give us the best chance at survival.
Thank you very much. I think that I'm hoping that our listeners can take away some really key points regarding some of the new technologies that are available, as well as the real importance of routine breast imaging and cancer screening, so that hopefully we can continue to improve outcomes and make cancer something that impacts fewer people, and if it does need to impacts them in the earliest possible stage. Thank you very much, Dr. Brem, for joining us.
Thank you for this opportunity.
Thanks for listening to our latest episode of Oncology Radio. You can find the broadcast on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. You can find more information about our physician hosts from Maryland Oncology Hematology at www.marylandoncology.com. Subscribe to our show on Spreaker at www.spreaker.com/user/oncology radio. And remember to follow the guidelines and get your cancer screenings for the best defense against cancer.
By law, every woman who has a screening mammogram must get her results in language that she can understand within 30 days of the mammogram. And it's important to realize that if you get such a letter that says, please come back for additional imaging, it does not mean that you have breast cancer. Most of the time it requires some workup, either a mammogram, an ultrasound, some additional imaging, and most women leave with the knowledge that they don't have breast cancer. If a biopsy is recommended, then biopsies should be done minimally invasively, much like going to the dentist. You don't get put to sleep. It's done in the radiologist or another physician's office. We use local anesthesia, and there's no stitches. Many people come to us during their lunch and go right back to work after their breast biopsy. And it's important to know that less than 20% of women who do have a breast biopsy actually have breast cancer. So, in order to find the smallest cancers, we have to sample a lot of different findings on imaging, and that's how we can find the earliest breast cancers. So if you come in for a screening, you come in during COVID, you should have assurances that breast centers are taking the necessary precautions. You come in, most often screening mammograms are not read at the time that you're there. If you do need to come back, don't fret. Most often it's really nothing. And if you do need a biopsy, even then the vast majority are not breast cancer. And if you do have breast cancer, then we live in a very fortunate time where the result of the incredible therapies we have, the opportunities to find early breast cancer, give us the best chance at survival.
Thank you very much. I think that I'm hoping that our listeners can take away some really key points regarding some of the new technologies that are available, as well as the real importance of routine breast imaging and cancer screening, so that hopefully we can continue to improve outcomes and make cancer something that impacts fewer people, and if it does need to impacts them in the earliest possible stage. Thank you very much, Dr. Brem, for joining us.
Thank you for this opportunity.
Thanks for listening to our latest episode of Oncology Radio. You can find the broadcast on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. You can find more information about our physician hosts from Maryland Oncology Hematology at www.marylandoncology.com. Subscribe to our show on Spreaker at www.spreaker.com/user/oncology radio. And remember to follow the guidelines and get your cancer screenings for the best defense against cancer.